Good evening, all. My name is Patty Roberts, and I'm Deputy Director with your City of Port St. Lucie Parks and Recreation Department. I am honored to sit and share with you tonight's 11th session of A Healthy You, a series of conversations on challenging topics which affect many of us. When I was actually writing that and thinking it, I thought, we've only been doing this 11 months. It's not even our 1-year anniversary. The 1 year will be next month when we actually talk about depression. So, but a few general housekeeping items, please. At the registration table, there is a voluntary sign-in sheet for anyone who wishes to leave their name. Again, it's voluntary only. Lastly, there will be an opportunity for questions at the very conclusion of tonight's presentation. Those in-person questions are very easy. Simply raise your hand and we will call on you. For those attending remotely, choose the Q&A icon, and that will let us know that there's a question waiting and in the queue, and we'll address those at the end of the presentation as well. So plenty of opportunity for questions and answers. Please take a minute to turn off all cell phones, and for those here in the room, the restrooms here are located right outside these doors and to the left. All right, what is Healthy You? And I know I have some returning people, so this will be a little bit of a repeat for you, but we'll get to the meat of the agenda tonight. But Healthy You is a program that's very near and dear to my heart. The topics that we've been discussing in this series of conversations over the last 11 months are ones that are very real and sensitive. We've covered depression, anxiety, domestic violence, trauma-informed care, suicide prevention, opioid use disorder, and those are all tough conversations to have. But if they're never talked about, the issues remain lurking and diseases are untreated. So that's the purpose. That's the very purpose behind Healthy You and just starting this very informal dialogue. And I have a very personal interest in exploring many of the topics that we've been discussing throughout the last 11 months. Just 1,145 days ago, and yes, I do count in days, my son Danny Roberts died from a heroin overdose that was laced with fentanyl. It was just over 3 years ago in August. And looking back on Danny's struggles, as he sought treatment at more than 14 rehabs and recoveries along the way, he was diagnosed with depression, anxiety, and bipolar disorder. Once when he was in remission, which is my term for it, that meaning he'd been sober for more than 2 years among the 8 that he fought, he and I had a great conversation, I thought, when I opened the dialogue with, what do you think came first, the mental health issues or your addiction? And Danny thought long and hard about it. It was right there in my kitchen, I remember it, before sharing his response. And he felt strongly that the mental health issue, that of anxiety, that's the first one that he presented with, was first for him. And then he began to self-medicate. As his mother, I didn't see that. He was very active in sports up until his freshman year in high school, and I didn't see the anxiety and depression that he suffered. And for that, I harbor deep regrets. So, you see, that's why I'm here, to learn more about mental health issues, and I do it every single session of Healthy You, so that I can help others maybe who are in need. Tonight's topic is bipolar affective disorder. It's very important to me, as you can imagine. I see how stress and bipolar and all the other mental health issues that we're presented with are adversely affecting the world today, everywhere around me. I saw it today in my own workplace, from my colleagues to my family to society in general. Self-care is critical, and that's what we're here for today. Throughout these days of COVID and prior to the pandemic even, the world in which we live in is moving faster than ever before. Technology has exploded. We were just chatting with our expert in the room about technology, and our means of connectivity is vastly different from how our parents before us connected and interacted with society. Many of us, due to circumstances outside of our control, feel isolated and unconnected with our loved ones, with our colleagues, our associates. And this can leave us feeling depressed, out of touch, with a weary outlook on life in general. Anxiousness has become our very way of life. And as we wake up each morning not knowing what our day will be like given the pandemic, finances, food security, housing, employment, all prove to be huge factors that can be heightened and exasperated in us all during these times. Today, it's my extreme pleasure to share with you an important message from a subject matter expert on the topic of bipolar affective disorder, Dr. Prescott with Suncoast Mental Health Center. And it's my privilege to read a little bit about Dr. Prescott and her immense qualifications to speak on this very topic. In 1994, Dr. Prescott graduated from Rowan University School of Osteopathic Medicine. She trained in general psychiatry at Albert Einstein Medical Center and then completed a child and adolescent psychiatry fellowship at the Children's Hospital of Philadelphia. Dr. Prescott is board certified in general psychiatry and child and adolescent psychiatry. Dr. Prescott is a fellow of the American Psychiatric Association. She has experience with teaching and supervising other mental health professionals. She's worked clinically with individuals and families who have been subjected to trauma and has developed programs to address the mental health needs of at-risk individuals. So without further ado, may I please share and introduce and give a warm welcome to Dr. Prescott.
Thank you. Thank you very much. I'm here today to talk about bipolar disorders. When I was first asked to give this lecture on this topic, I nearly choked to death because this is probably one of the most misunderstood diagnoses in psychiatry at this point. I always like to refer to specific diagnoses that are overdiagnosed as diagnosis du jour. Bipolar right now is diagnosis du jour because, for real, people don't follow the diagnostic criteria to actually qualify for this disorder. I guess I'm doing this. All right, let's see. Good. With bipolar disorder, you need to meet specific diagnostic criteria. First and foremost, you must have a manic or a hypomanic episode, okay? When it comes down to mood, mania is bigger than life. This disorder itself is not diagnosed by the presence of mood swings. When people come into my office and I get a history on them and ask them about their past psychiatric history, I say, okay, well, what has anybody said you had? Bipolar disorder. Why? I have mood swings. Well, I'll tell you something. I have mood swings probably daily. If you catch me when I don't sleep, they come far more frequently, but I can assure you I am not bipolar with this. This is a brain disorder. It is a physiologic disorder that messes with your mood, so you have changes in mood, you have changes in your energy, functional impairment happens, and a lot of people who say that they have some type of psychiatric diagnoses actually are people who have normal human emotions. Impaired functioning is paramount in this field, although people will really, call themselves something when you must be functionally impaired in order to be successfully treated, to go back to being functional. Okay, so in bipolar disorder, in many psychiatric disorders, how it presents is through a behavioral change. That's what we see. That's probably why so many people are afraid of psychiatry, which the brain is biology, what I like to call microneurobiology, because we can't see it. If we can't see it, we don't understand what it's about, so we become afraid of it. When it manifests in behavioral changes, that's when we're kind of, something's wrong here. Bipolar disorder, too, when people are active, it impairs relationships. People just aren't acting the way you expect them or want them to act. So, this disorder affects about 1 to 2% of the population, okay? 1 to 2%, not like 70, 80, 90% of us who have mood swings. You'll see in different psychiatric disorders that men may have it more, women may have it more. With this one, it's equally distributed between men and women. It starts to rear its ugly head in general somewhere in late adolescence to early adulthood. Then you see, well, all teenagers are moody, but in teen years, things become bigger. So when symptoms present, we talked about that before, this is generally when they're presenting. We don't know whether it's teenage angst or actually if a psychiatric disorder is going on. 80 to 90% of people who are diagnosed with what I will call actual, for real bipolar disorder have a huge genetic link. 80 to 90% of the people who are accurately diagnosed truly have another family member with the disorder. I always like to mention this too. In the general population, we probably have somewhere around the 1% rate of suicide in the overall general population. The suicide risk with bipolar disorder, and other mood disorders too, is about 15 times of the general population, 15 times higher. To me, that's amazing. When you talk about the general population with suicide, you have one suicide every 11 seconds. Multiply that by 15. Okay, so manic and depressive events, what do they get triggered by? Stress. We all have stress in life, but when you're under pretty bad stressors, you have the tendency to melt down. Once again, even if you're not diagnosed with a psychiatric disorder, it's kind of difficult to deal with stress in our day-to-day lives without having some type of emotional reaction. Sleep disruption. I always say to people who have mood disorders, the best drug I could ever give you is sleep. But I can't really do that for people. But sleep is a wonderful drug when it comes to stabilizing our moods. Drugs and alcohol can definitely kick off manic and depressive episodes. When you talk about the chicken and egg phenomenon, yes, many people treat themselves with alcohol or drugs when they have some type of psychiatric disorder going on, but also you can kind of see it in the opposite direction too. And just because people have mood swings or ups and downs when they're using things to medicate themselves, once again, doesn't mean they're bipolar. Some medications, sometimes, say you're depressed, you go into your doctor's office, let's put you on an antidepressant. Sometimes that can precipitate a mania where you go through the roof. There are other medications, I mean, people have probably had any type of inflammatory thing, maybe poison ivy and you get steroids. Steroids could kick it off. So there are many different types of medications that can really send you on your way. One of the things that I'm not really, I don't really like is, this has often been referred to in the past as a chemical imbalance. I'm going to go back to my phrase, microneurobiology. We can't see it. We know that there are chemicals there, that the chemicals in the brain talk to impact our mood and the way we think. But chemical imbalance just sounds way too dismissive. Mania. What you must have in order to be truly diagnosed with bipolar disorder is a manic or a hypomanic, so the hypo is lower but still looks the same. It has to be there for at least a week. When I ask people about their sleep, oh, have you had periods where your sleep has been abnormally decreased? Oh yeah, well I didn't sleep well for 2 nights. Okay. You really have to have this stuff going on for at least a week in order for us to make, how do I say this? In order for us to start thinking about this being an actual psychiatric disorder instead of you're under some stress and couldn't sleep for 2 nights. Mood disturbances, and we have this lovely book where we get, or we make diagnoses from, called the DSM-5. So if you fit into certain categories, you meet diagnostic criteria, and congratulations, you have what you got. So with mania, you have to have mood disturbances, at least 3 of the following. Inflated self-esteem or grandiosity. I am Superman. I can do anything. I'm a lot better than you and you and you. But you know, in reality, you're not the greatest thing on earth. Decreased need for sleep. I just kind of hammered on that. Days and days and days. If you're normally an 8-hour sleeper and you're sleeping 3 hours a night or not sleeping at all for days on end, you might be manic. People talk a lot, okay? Sometimes they talk so rapidly, you can't even butt in. It's, excuse me, can you please stop? So the rapid talking goes along with it. We have something called flight of ideas. So that person who's rapidly talking might be talking about one subject, then jumping to another, jumping to another, jumping to another, sometimes rounding and coming back. Other times, you'll just never get it. Distractibility. Okay, most of the people in the world that I know at least are distractible, but truly little things setting you off where you can't follow a conversation. You cannot, once again, follow along. We have an increase in goal-directed activity. Everybody likes to be productive, but some of these people can be ultra-productive. Usually when they're hypomanic, not manic, then they think they're doing a lot of great and wonderful things where they may actually not be doing them. However, people don't like to get rid of their manias because they feel so productive. You can get agitated. Maybe this is where the mood swings thing comes in. Little things can set you off where they generally don't before. And people get impulsive when they're manic, which means that they act before they think. So if I really have wanted this, give me a good thing that I would want to buy but really wouldn't. Let's say a Rolls Royce, okay? That's a good one. Can't afford it, don't really need it, but you know something? I'm going out today and buying it. That's something impulsive. Some people get involved in damaging relationships. They're indiscriminate with sex. That they'll do things that can actually hurt themselves physically, financially, socially, anything like that. We have that impulse control problem. Always go back to functioning, functioning, functioning. You'll see a diminished ability to function socially, at school, in your job. You cannot do it. I think this is an important one, that this doesn't happen directly because of a medication that people abuse or substances, okay? If someone is smoking crack, if they're doing PCP, if they're doing ecstasy, guess what? They can look very, very manic. However, it's not due to bipolar disorder, it's actually due to the substance itself. Important thing in mania or hypomania, people do not think they're sick. They think that the world is great and they don't need anything but themselves and they can accomplish so much. And if you feel so good, why would you want anybody to bring you down? Which brings us to the other side of the world, depression. So depression is depression. If you don't have a manic or a hypomanic episode, it ain't bipolar. Then you're going to go to the depression side. Diagnoses for depression, this is something you need to have around for 2 weeks. You're depressed most of the day, or nearly every day that depressed. You don't feel like doing anything. You have a complete loss of interest or the pleasurable things that you're used to doing. Some people stop eating. Some people start eating too much. So it doesn't necessarily mean because you're depressed you're never going to eat. Some people overeat in order to comfort themselves. Sleep disruption. Once again, sleep is the greatest drug in the world. When people are depressed, manic people we know don't sleep. Depressed people might be able to fall asleep, but they're waking up a few times a night, or they're waking up a couple hours prior to when they normally wake up. They can't get back to sleep. If you have a disrupted sleep cycle like that, you certainly are not going to have that drug that you need to kind of calm your mood and keep it stable. You can have what we call psychomotor agitation or retardation, where when people just don't have the energy to do anything, we call that psychomotor retardation. And agitation, just think about the opposite. People are often fatigued. They don't have much energy. They're tired all the time. They're not motivated to get up and go and do anything. When you can't do what you feel you're supposed to do, you start feeling guilty. I'm guilty, I'm not functioning, therefore, I'm worthless. I can't do what I used to do. I'm just worthless. You can't think straight. You know, when you take that article on the internet, you're reading the same sentence 7 times and it still doesn't make sense, and you can't comprehend it at all. One of the things we're most concerned with at this point, too, is people's recurrent thoughts of death. I feel so bad, I don't want to be here anymore. So obviously that's concerning and needs to be addressed anytime we hear about it. Going to go back, has to cause functional impairment in your life. Why initially the first slide said bipolar disorders is because there are disorders, not just one size does not fit all. We'll talk about bipolar 1, bipolar 2, and cyclothymia. Bipolar 1 is what most people consider, oh my God, this person's bipolar. Completely over the top. Somebody who is in a truly manic episode, you can see, they exhaust you when you're near them. Okay, bipolar type 2 is generally not that full-blown manic thing, but more hypomania. So these people are far more goal-directed, and people that may not be caught as much, because sometimes they aren't too terribly impaired, and once you get to the point of functional impairment, then you really have to look at it. Cyclothymia, just think of it as baby bipolar 2, because it's pretty much the same thing. We're all looking at those periods of time where people are too energetic, where they're making stupid decisions, etc., etc. Rapid cycling. Another thing that generally makes me want to choke. People say, oh, I rapid cycle because I'm happy for an hour and then I'm miserable for 2 hours, and that's not rapid cycling. Rapid cycling is actually having an episode, a true episode, whether it be of mania or depression, at least 4 times a year, which it may happen more frequently than that, but it's not happening on a daily basis just because you're agitated and your mood is going up and down. Mood swings do not equal bipolar. We don't understand rapid cycling. Why do some people do it? Why don't others? Hey, we don't know, but I'll tell you, in psychiatry, we don't know a whole lot. When we talk about comorbidities, that's what other psychiatric stuff can go along with this, okay? You heard a little bit from Patty, okay? We talk about other things like anxiety, panic disorder, not leading to, but also diagnoses like binge eating disorder, attention deficit hyperactivity disorder. I actually see a pretty good correlation between the two. Borderline personality disorder, which is way too big a topic to get into. Alcohol and drug use. Once again, you have a psychiatric disorder, and generally it's anxiety or an anxiety-related disorder. What makes you feel good? Alcohol. What makes you feel good? Opioids. If you're depressed, what makes you feel good? Cocaine, crack. Unfortunately, it's very difficult, once again, to identify the people that actually have emotions that they perceive as debilitating, especially when we watch them and they appear functional. However, I can tell you that they will say in the books that there is probably somewhere around a 35% comorbidity with substance abuse and a psychiatric disorder. Personally, I think it's around 70%. Which came first, the chicken or the egg? I really think it's the psych disorder that often comes first. We're still stigmatized, although it's a lot better nowadays. But people don't want to be diagnosed with a psychiatric disorder. Guess what? Alcohol's far more socially acceptable, and God, it makes me feel less anxious. That's kind of how we gravitate toward these things. But also remember, bipolar does not in itself have to happen alone. You can have many comorbid psychiatric disorders that go hand in hand with it. I'm a psychiatrist, I'm a medical doctor. When people talk bipolar, they always want to talk medication. So let's talk a little bit about medication. Bipolar actually is what I will call a brain disease on a level we can't see. So we know that our first interventions need to be biological, because as much as we would love to provide non-pharmacologic supports around people, I am super, super conservative in my prescribing practices. If it doesn't look like, or the symptom is actually presenting in a way that needs to be treated, I won't give medication. With this disorder, you've got to give medication, because you will not achieve stability with a person who has phases that it may take a year to get back into a phase, but have these phases where life falls apart. So we talk about mood swings. What do we use? First line for bipolar disorder, a mood stabilizer. Of course, we'd like to get back to middle ground somehow. The mood stabilizers that we use today are kind of different than the gold standards of long ago. Everybody has heard of lithium. Lithium is an incredible mood stabilizer. The unfortunate thing is there are many, many problems or potential problems that you can have simply by being in the heat. If you sweat too much, you can throw your lithium level to a toxic level, and many bad things can occur when you're lithium toxic. So I don't know how people decided to start looking at this, whether it was whether they were actually trying to do something or just tripped across it. Anticonvulsants. Okay, so you think about epilepsy that get treated with anti-epileptic medication, or known as anticonvulsants. We will use anticonvulsants to achieve mood stabilization in a lot of the population. So Depakote became like number 2 after lithium, and lithium started losing its allure. Depakote is an anti-seizure medication. However, we do have some problems with a lot of our psychiatric medications. It packs on the pounds. So we started playing around with more. Tegretol or carbamazepine, also anti-seizure medicine. Doesn't really pack on the pounds as much as the Depakote. Yeah, but it could make you lose your white blood cells. There's a lot that goes along with it. Lamictal or lamotrigine, very well tolerated by many people. Very, very rarely does it happen, but it does happen that some people get something called Stevens-Johnson syndrome. What's that? It's a rash that makes your skin fall off. So that's not a great thing too. Topamax or topiramate, they're also using that a lot now for migraines, for different pain syndromes. And actually they created a diet pill that was a mix of topiramate and naltrexone. It hasn't gotten a lot of popularity, but hey, it's out there. Neurontin or gabapentin, people know it as. Not as common for us to use it as a mood stabilizer. However, it can be a good mood stabilizer for some people. Using a lot now with neuropathic pain, so nerve pain. Are antipsychotics, and we call these atypical antipsychotics or second-generation antipsychotics. Things like Seroquel, which is quetiapine, Risperdal, risperidone, Zyprexa, olanzapine, Geodon is ziprasidone, Invega, paliperidone, and Abilify aripiprazole. They're coming out with new ones every day that are getting indications for it. If you're going to use a medication, truly you better have a symptom profile that is, I don't want to say worth treating, but is significant enough to require treatment. All the medications have benefits and drawbacks. Many psychiatric medications will make us gain weight. As we gain weight, that can lead to type 2 diabetes and a whole bunch of other stuff that goes along with it. So we want to be judicious when we do this. On this slide, it says first generation antipsychotics, boop, out of favor. Okay, that's the stuff like maybe you've heard in the past, Haldol or Thorazine or Mellaril. Okay, they're old ones that basically we don't use a whole lot anymore. And we don't even know how great of a mood stabilizer they actually are. Talked about lithium. And now we're going to get into antidepressants, because remember, antidepressants can be kind of dangerous if they can rev you into a mania. However, with a lot of people, they actually do require an increase in mood because they'll show themselves more as depressed than the manic or hypomanic part. Antidepressants, my God, you hear them on TV every day. You've heard them in school. You've heard them at work. It's almost like everybody's on one now. So we have a few different categories of antidepressant medication that we commonly use. Serotonin-specific reuptake inhibitors. Most people know it as stuff like Prozac, Paxil, Luvox, Celexa, Lexapro, Zoloft. And we got more, and they're coming out every single day. We have something that we call SNRIs, which would be serotonin and norepinephrine reuptake inhibitors. Their chemicals, they have enough of them around, they're happy chemicals. So you may have heard of stuff like Affective or Cymbalta or Prestique or Remeron. The one that is novel that nobody has really matched is Wellbutrin, and that has a lot to do not only with norepinephrine but dopamine, so it doesn't affect the serotonin system at all. Also with the dopamine, they will turn that around. Instead of calling it Wellbutrin, they'll call it Zyban, and it helps you quit smoking. Tricyclic antidepressants are old antidepressants. Once again, pretty much has fallen out of favor. We do use them for their side effects, however, because many of them make great sleeping pills. Also puts a lot of weight on you. Anti-anxiety medications, we like to use them in the short term if we have to use them at all. And those would be the things most commonly known as like Xanax or Ativan or Klonopin, tons of other ones that go along with it too. But in that family, with those medications in particular, they can actually physically addict you, but also cause incredible psychological dependence. When you feel anxious, you take a pill and it goes away. It's kind of reinforcing to take the pill again when you feel anxious. So that's the psychological piece of it, but there also is a physiological piece of it. And if you're taking a lot of it and just pull it off, you can have a seizure. The supportive stuff, which is the other things that we use in addition to the biological interventions, would be your things like, okay, therapy. What types of therapy? We like to use cognitive behavioral therapy a lot, and the cognitive part is using your thinking brain to impact your behaviors and kind of practicing it in a way where you develop a skill set. Good stuff for a lot of different disorders. Insight-oriented therapy, which is what most people consider, what therapy is. You tell me about your problems. But it's to try to gain some insight into the problem itself, and then it gives you a better idea of how to manage the problem. Supportive therapy, when some people are incredibly impaired, they just need somebody to sit down with them, to support them, to help them know that they're okay, they will be okay, and kind of blow off steam. Group therapy, I love group therapies, period, because peers, other people in the group, I think are the most effective counselors and therapists that you can have. People, when they relate to each other, hey, it's way more healing than me talking to you saying, okay, you feel really bad. Okay, I haven't experienced the same experience. I can empathize with you, but I don't know what your reality's like. Psychoeducation, the more you know about something, the less scary it becomes. Peer support, and that's outside of a group therapy setting. Just support organizations, when you think of overall many of the mental health disorders, something like National Alliance for Mental Illness. Although I don't like the phrase mental illness, I'll go back to microneurobiological disorder. So you have those other supports that can really put a treatment plan around a person to help them be more functional. Because remember, the name of the game here, where we want to get to, is functioning appropriately. That is the end of what I have to say.
I will, again, a round of applause, please, for Dr. Prescott. That really was educational for me, and I really appreciate you guys all coming out. And stay tuned. The next session of Healthy You is November 3rd. And right back here in this room, same type of setup. And we will have a presenter speaking on depression, which I know we had once before in this session, and that's a hot topic. So feel free to come back. Every session's free, and thank you guys so much for your feedback. Thank you.